Good morning. On behalf of Western Kentucky Heart and Lung Research Foundation and Educational Trust and our founder and president, Dr. Mohammed Kazmuddin, we'd like to welcome you to our 6th annual Cardiovascular Symposium. The Western Kentucky Heart and Lung Research Foundation is a not-for-profit organization designed to encourage and promote research among the South Central Kentucky's physicians, fellows, residents, and medical students, those associated with MedCenter Health and the University of Kentucky College of Medicine, Bowling Green campus. We'd like to thank everyone for joining us, and we hope that you will be enriched with the expertise and knowledge of today's speakers. I now have the honor of introducing the chairman for the WKHL Research Foundation, Dr. Aniruddha Singh. Dr. Singh is the Director of Preventive Cardiology and Vascular Medicine for Western Kentucky Heart and Lung and the Director of Research for the Cardiovascular Fellowship Program. Dr. Singh has served as Chairman of the Western Kentucky Heart and Lung Foundation for the past 4 years. Please welcome Dr. Aniruddha Singh.
Good morning. It's my pleasure to welcome you all to the first day of the combined Western Kentucky Heart and Lung Research Foundation and the Kentucky chapter of American College of Cardiology meeting. My name is Dr. Aniruddha Singh, and I'm the chairman of the Western Kentucky Heart and Lung Research Foundation. I would like to take this opportunity to give a brief overview of the foundation, its mission, and the cumulative goals it has accomplished that have impacted the overall medical environment in South Central Kentucky. The Western Kentucky Heart and Lung Research Foundation and Education Trust is a multidisciplinary collaboration of physicians, trainees, and other healthcare professionals who provide the support necessary to encourage and advance healthcare professionals in their pursuit of innovation and clinical excellence in medicine. Over the past 6 years, we, together with the remarkable leadership and experts at MedCenter Health, the University of Kentucky Healthcare, and Western Kentucky University, have comprehensively transformed an ambitious community hospital teeming with opportunity into a fully integrated institution for medical education, ever expanding its reach. Our success has not been met without obstacles, something that has become even more prevalent in the face of the current COVID-19 pandemic. Bowling Green and Warren County have been most prominently affected by the virus. To combat the intricate and growing rate of infection, a similarly complex approach must be used to understand and remedy its effect. In support of such, we at Western Kentucky Heart and Lung, with the help of the wonderful statisticians and support at Western Kentucky University, have conducted several studies centering around the COVID-19 pandemic. Further, the foundation has partnered with the Medical Center and Commonwealth Health in securing grant funding to expand its current telehealth network. It is our hope that through these efforts, we will not only make noteworthy additions to the literature pertaining to coronavirus, but also add to the overall state of healthcare in our service area. COVID-19 has led to significant changes in healthcare delivery and access. Delivery of medical education during the pandemic has been challenging, as the number of healthcare individuals need to be limited at the hospital and in our clinics. A fundamental shift in clinical education from bedside to online format is required. Recognizing this imperative need, the Western Kentucky Heart and Lung Research Foundation decided to collaborate with the Kentucky chapter of the American College of Cardiology to host a 2-day event. We hope that the audience would thoroughly enjoy listening to and interacting with our distinguished speakers. Our audience would also be able to view the multiple research studies that have been put together by our trainees and their mentors. I would like to personally thank everyone who is in attendance today. We hope that you would find this experience to interact with colleagues and experts to be both professionally and personally rewarding. The symposium today will have 4 sessions. You will have an opportunity to ask speakers your questions once they are done with their presentation. I, on the behalf of Western Kentucky Heart and Lung Research Foundation and the Kentucky chapter of American College of Cardiology, hope you have a great first day. Now, I would like to introduce our first speaker, Dr. James Slater. Dr. Slater completed his residency, chief residency, and cardiology fellowship at the New York University. He was involved in the first balloon angioplasty performed at NYU, as well as participated in the early trials that established the value of thrombolysis in patients with acute myocardial infarction. After 10 years as an instructor and as an assistant professor at NYU, he moved to St. Luke's Roosevelt Hospital as the director of their cardiac catheterization lab. There, he participated with Dr. Judith Hochman in the SHOCK trial and the OAT trial, while helping introduce rotational atherectomy and stenting in their clinical practice. In 2002, he returned to NYU, where he introduced ASD and PFO closures, as well as percutaneous mitral valve clipping through participation in the Everest trial. In 2008, he became the director of the NYU Cardiac Catheterization Lab, as well as the director of the Structural Heart Program. He participated in the core valve trial, and he performed over 250 transcatheter aortic valve replacement procedures during this time. He also worked closely with Dr. Judith Hochman on the ischemia trial. After 36 years of interventional cardiology practice, he began overseeing the quality control of the NYU Cardiac Interventional Lab. I would like to thank Dr. Slater for sharing his experience and expertise with us all today.
Hello, I'm going to be speaking today about advances in treatment for stable angina. My name is Dr. James Slater, and I'm a professor of cardiology at NYU Langone Medical Center, and I'm very pleased to be here with all of you today. Just to put some historical perspective into what we're going to talk about today, I came across this slide about atherosclerosis in ancient Egyptians. And you can see that it's been around a long time, that Egyptian mummies had actually about a 50% incidence of atherosclerosis. It's actually a 30% incidence of atherosclerosis, which in modern Egyptian patients has increased to about 54%. And you can see that the disease is much more widespread now than it was way back when, 3,000 years ago, and now involves more commonly multiple vascular beds. Well, let's just zoom in on the United States with regards to this problem right now. And you can see that in an analysis of the scope of atherosclerosis in the US published in 2015, that if you looked at all manifestations of coronary artery disease by age and sex, you'd see that by the age of 80 years old, about 32% of men had some manifestation of coronary artery disease and about 19% of women. If we hone down a little bit further and look at stable angina in the United States, we can see that by 80 years old, 10% of men and about 11% of women have some manifestation of what we would consider to be stable angina. And that turns out to be about 30 million people. So you can see that this is not a rare clinical problem. And let's just focus for a minute on what actually does stable mean. Stable angina describes a pattern of clinical symptoms, but it really doesn't tell us very much about the pathophysiology of the disease. Another way to talk about it is to label it as stable ischemic heart disease, which implies a characteristic about the long-term nature of the condition, which may or may not be true. So perhaps a more accurate way to describe this would be to call it a chronic coronary syndrome. And perhaps that's a little bit less misleading a term that implies the need for a careful ongoing assessment of these patients, because in fact, their disease may not always be stable. So what is the approach that we currently have for the patient with a chronic coronary artery syndrome? And you can see from this slide that it's actually quite complicated. It involves, number one, making a diagnosis, which relies on symptoms and frequently non-invasive testing, whether it's an EKG, echo, nuclear, or PET stress test. And that could be either with exercise or by pharmacology. It also could involve the use of a CT coronary angiogram, or combining that with certain advanced technologies to do an FFR assessment based on that CT angiographic image. Then, of course, we move on to treatment, and that involves medications, lipid lowering, antiplatelet, anti-anginal, all the ones that you're well aware of, including behavioral modifications, diet, bad habits. And then there's more advanced treatment therapies, such as revascularization, either with PCI or PCI with physiologic lesion assessment. And there's also now the ability to treat chronic stable angina with CTO manipulation, and of course the old standby bypass surgery. And last but far from least is follow-up, and longer-term results of revascularization, compliance issues concerning medication are all major concerns of the physician taking care of a patient with chronic stable angina over the long term. And then you always have to keep up with the continuing advances in causation. For example, what's the role of Lp(a) in the causation of this disease? What's the role that inflammation is playing, as well as possibly new and continuously evolving chemo and hormonal therapies, whether they be for oncologic conditions or rheumatologic conditions, et cetera. So let's just talk about some general thoughts concerning diagnosis. And what comes to my mind is that revascularization or medical therapy will not improve chest pain if it's non-cardiac in nature. And some of the common co-conspirators, of course, are anxiety, arthritis, and lung disease as well. And there's also the issue of misinterpretation of non-invasive stress testing, which is quite common. And factors that make this more frequent are obesity, left ventricular hypertrophy, EKG abnormalities at baseline. And of note, it's interesting that 14% of positive stress tests that the local sites reported in the ischemic trial were actually not confirmed by the core lab. So there's also the issue of local interpretation and reading of the tests where there may not be adequate quality control. The other point that I would just like to make about diagnosis is that revascularization will not improve angina when it's based on a false positive stress test or non-obstructive lesions that are found at angiography. Well, one of the things that we see is that the number of PCIs that are actually being done in the United States has kind of dramatically fallen in the last 13 years. So here's a graph of the procedural volume per 100,000 patients, and you can see that it's about a 50% decline over that 13-year period with regards to PCI. And there's a smaller decline in CABG, although when you look at the New York State database comparing 2000 to 2010, there actually is a 50% decline in bypass surgery during that period as well. And you can see here that the same trend does not hold true for STEMI or for NSTEMI, that the amount of PCI being done for those conditions is staying relatively stable. And for STEMI, it's actually probably increasing a little bit. So why is this 50% reduction in PCI in the United States taking place? One is probably that there's evidence from multiple clinical trials showing no relief from the hard endpoints of MI or death. There's also the introduction of guidelines and appropriate use criteria, which have had an impact. In addition, there's physiologic assessments of individual coronary lesions that are discovered at diagnostic catheterization, and that stays the hand of some of the interventionalists at certain points. Another factor may be better medical therapy for risk factor control, and also better interventional therapies, stents versus balloons, and second-generation drug-eluting stents versus bare metal stents, which reduce the number of repeat visits to the cath lab from people that have had initial interventions. So when we look at the role of PCI in the treatment of acute coronary syndrome and stable angina, we can see that there's really been a number of trials that have taken place to address the syndrome over the years, and they've concentrated on unstable angina, which you can see are the first three categories at the top of this slide, and stable CAD, which is the very last one. And at least as far as the impact on CV mortality, we can see that it appears that intervention for unstable syndromes, STEMI and unstable angina, appear to be beneficial, and they seem to reduce the incidence of death and MI, although among some investigators, this still remains somewhat controversial. And I think also that the data in this regard suggests that the more unstable you are, you've made a troponin as to not have made a troponin, that the more beneficial interventional approach can be. But when we go down and we look at stable coronary disease, and you see there's the RETA-2 trial here, there's the COURAGE trial, FAME-2, and even ischemia has made it onto this meta-analysis, that there really is no effect of intervention in a meta-analysis of all these trials on CV mortality. Well, how about myocardial infarction? Here's the same analysis focusing on that. And you can see that even compared to death in the unstable syndromes, there's a greater impact of benefit for the treatment of myocardial infarction. But again, once we move into the stable syndromes, we move right back to the line of identity, and there seems to be no benefit combining the results of all of these trials. Well, let's just focus on the last trial that was done and see if we can get a little bit more detail by drilling down a little bit more. And that's the ischemia trial, which was presented at the American Heart Association in Philadelphia in October of this year. I guess it was November, excuse me, and was published in the New England Journal in April of this year. And they asked the basic research question that in stable patients with at least moderate ischemia on a stress test, is there a benefit to adding cardiac catheterization and, if feasible, revascularization to an optimal medical therapy? It's the same old question, but again, time moves on and we have different ways to approach this and different weapons in our arsenal, if you will. So what were the endpoints of the trial? The primary endpoint was a composite of time to CV death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And there were some major secondary endpoints, time to CV death or MI, and quality of life, which we'll talk about. And it's very important to understand the eligibility criteria, which were relatively simple: age over 21 and moderate to severe ischemia on either a nuclear, echo, MRI, or exercise EKG stress test. And you can see the criteria for those definitions of moderate ischemia on the slide. And the exclusion criteria are also quite important. People with heart failure, class 3 or 4, were not in this trial. Unacceptable, even so-called stable angina, despite medical therapy at baseline, was ruled to be an exclusion. A low ejection fraction, less than 35%, an episode of ACS within 2 months, prior PCI or CABG within a year, or a GFR less than 30. So patients with significant renal disease are not included in this cohort as well. And here's the study design. Basically, we have these stable patients with moderate or severe ischemia. They all undergo a coronary CT angiogram, which is blinded to both the investigator and the patient, the results of which, and you'll see why in a second. If the core lab anatomy appears to be eligible, then they go on to be randomized to an invasive strategy, which is optimal medical therapy plus cath and optimal revascularization, whether that be by angioplasty, stenting, or bypass surgery, or a conservative strategy of optimal medical therapy alone with cath reserved for a failure of optimal medical therapy. Not all the patients got a coronary CT angiogram because some of them had GFRs between 30 and 60, and they were excluded from that requirement. And some of them had their coronary anatomy previously defined, so that step was skipped. So if we just drill down a little bit further and see actually who got enrolled and randomized in this trial, we could see that 8,518 patients were enrolled and about 3,300 were excluded. Some did not have obstructive coronary disease, others did not have enough ischemia on their stress testing, and some had unprotected left main disease. 5,179 underwent randomization, and of those, about 2,500, 2,600 were assigned to an invasive strategy, and 2,600 were assigned to a conservative strategy. As the red arrow points out, the follow-up in this trial was quite remarkable, with almost 99% of patients, or more than 99% of patients, had completed follow-up, which is really quite impressive. This is a slide that you can't read, which really doesn't matter because it's just outlining the baseline characteristics of the patients. And to make a long story short, there is no difference in any of these baseline characteristics between the people that were randomized to revascularization or optimal medical therapy. So here's the meat of the matter right here. And you can see that these are the time to event curves, or Kaplan-Meier curves, of the primary composite outcome. And you can see that that there is initially a trend towards maybe a worse outcome in an invasive strategy, but at about 2 years, those lines cross over, and it appears that the invasive strategy, if anything, is holding its own. If we move on to the even more important things of, say, death from cardiovascular causes or myocardial infarction, you can see again that at about 2 years the curves cross. But at the end of the game, at the end of the day, those two lines are not statistically different. And death, of course, which do Malone counts, is spot on. I mean, there is no signal whatsoever that there's any preservation or prevention of death from a revascularization strategy in the treatment of people with chronic coronary syndromes. And looking at subgroup analysis to see if there's any heterogeneity of a treatment effect. If in one particular subgroup it looks like there's a clear advantage of an invasive strategy, it appears that that's not the case. Even surprisingly, in patients with very severe coronary disease based on 50% stenosis in 3 or more vessels, there's no difference between optimal medical therapy versus OMT plus revasc. Whether that involves the LAD, diabetes didn't pan out, or baseline ischemia. Even patients with severe baseline ischemia on their stress test had no real signal that an invasive strategy was superior to an optimal medical therapy alone. But let's just look at MI a little bit here, because this becomes kind of an interesting story. There were 2 ways that they looked at MI. One was with a primary definition, which was a CKMB greater than 5 times the upper limit of normal, plus EKG changes and or angiographic evidence that that there was some compromise of vessel anatomy. And there was a secondary definition, which was a troponin, which is more than 5 times the upper limit of the 99th percentile. And you can see that there's quite a difference in the amount of MI that you count when you use these 2 different techniques. And so in the invasive group, especially, that using the secondary definition, there's much more periprocedural MI using troponin than CKMB, and contrary, in the conservative group, there's much more type 1 MI. And it didn't matter whether that was by the secondary or the primary definition than in the invasive group. And that's kind of an interesting finding, which we'll try to explore a little bit more. So the summary that the investigators made about these observations was that the relative risk of the primary and major secondary endpoints between treatment strategies was strongly dependent on the MI definition that was used. And procedural MIs were more frequent in the invasive strategy, regardless of the definition, and spontaneous type 1 MIs were more frequent in the conservative strategy. And the mechanisms underlying the relationship for type 1 MI reduction with the invasive strategy are not entirely clear. Potential explanations include the effectiveness of revascularization on a lesion that potentially would become a source of complete occlusion and STEMI, or a greater use of DAPT in these patients, for example. And the longer-term follow-up of the ischemia cohort will determine if observed differences in these MI rates and type translate into differential treatment effects on mortality. Now, here's another interesting aspect of the trial, and one that made a lot of interventionalists a little bit happier than the previous slides, and that's the treatment effect on, regarding the symptom of angina. And you can see that using the Seattle Angina Questionnaire, where a score of 100 means you don't have any angina, and a score of 0 to 20 or 30 means that you're having daily or at least weekly angina, so it's much more frequent. And you can see that that just honing in, let's just say at the month 36, which is now 3 years out, and the average follow-up in this trial was 3.2 years, that you can see that the number of patients in the invasive strategy that are angina-free is much higher than in the group that received the optimal medical therapy alone. But the group of patients that have Seattle Angina Questionnaire scores of 50 or above, you can see that there's really very little difference or very little effect of revascularization on their clinical syndrome. So what were the politically correct conclusions of this trial, which the investigators would discuss during their presentation or their New England Journal manuscript? That among patients with stable coronary disease and moderate or severe ischemia, there was no evidence that an initial invasive strategy as compared with an initial conservative strategy reduced the risk of ischemic cardiovascular events or death from any cause over a median of 3.2 years. The trial findings, however, were sensitive to the definition of myocardial infarction that was used. And finally, the modest mean difference favoring the invasive strategy in the overall group reflected minimal differences among asymptomatic or minimally symptomatic patients with the strategy of revascularization, and a much larger difference among patients who had angina had significant angina at baseline. So the invasive strategy definitely reduces the clinical impact of angina on the daily life of patients with chronic coronary disease. Well, there's some other perspectives that maybe are a little less PC that I would like to throw out for your consideration. One is that the results are in line with other randomized controlled trials that have addressed this question. For example, Courage in 2007, Berry 2D in 2009, Fame 2 in 2012. They also showed no statistical difference in death or MI with routine revascularizations in patients with stable coronary disease. The overall outcomes, however, at 5 years, when looking at death or MI, are better in ischemia than Courage. 12.4% of patients had death or MI, combining the optimal medical therapy and revascularization groups because they're not statistically different, versus almost 19% in patients in Courage, which is 13 years ago. And that suggests that there are possible improvements in medical therapy and interventional techniques that have occurred in the last decade that impact the treatment of these patients. And there's strong evidence in ischemia that patients with worse angina exhibit much more symptom relief with revascularization than with optimal medical therapy alone. And there was a 22% crossover rate from optimal medical therapy to revascularization. However, there was no difference in patients with no or monthly angina. So as doctors, we like to save lives and we like to prevent, very serious other illnesses from occurring, like myocardial infarction, but we also like to make our patients feel better, and there's nothing wrong with that. And it looks like in the right group of patients that ischemia showed that intervention definitely impacts sort of the day-to-day clinical symptomatology of this disease. Continuing in this regard, there's a strong signal that type 1 MIs may be reduced with the revascularization strategy, but longer-term follow-up will be needed to confirm this, and that peri-PCI and CABG MI remains a concern, but appears to be less lethal than spontaneous type 1 MI. CTA also may emerge to play a larger role in clarifying treatment by identifying patients with non-obstructive disease despite a positive stress test, while also revealing very advanced and left main disease. And I think as time goes on and the resolution of CT angiography improves, which of course it will, that we're going to see much more impact of this in the management of our patients. It's important to realize again that patients with a low ejection fraction, aggressive stable angina at the beginning, left main disease, heart failure, and poor renal function are not included in the ischemia cohort. So let's look for a second at what other information there is about long-term outcome after PCI for stable ischemic heart disease. And there's a recent publication actually in April of this year by Madhavan, which was a pooled individual patient level data from 19 prospective randomized stent trials. And it has the advantage of a large number of patients, almost 11,000, of which 1,550 had bare metal stents. About 3,000 had first generation drug eluting stents, and almost 6,500 had second generation drug eluting stents. And what they found was, of course, that surprisingly or not surprisingly, that putting a stent in does not, cure coronary artery disease or the manifestations thereof in patients with stable angina. And you can see that when you look at overall MACE, that bare metal stents don't do so well, that by 5 years, 25% of patients have had some sort of manifestation of unstable angina or recurrent revascularization, MI, or death. Whereas patients with second generation DES, that number drops to 13.4. If you look at cardiac death, there's really not much difference, with it being about 3.5% roughly at 5 years. If we look at myocardial infarction, interestingly, first generation stents, drug eluting stents, don't do as well, even as bare metal stents, and certainly second generation stents. And of course, that was first reported from the SCAR registry from Sweden, and was a big red flag warning about when we first started to use drug eluting stents, that maybe the prevention of re-endothelialization was setting patients up for stent thrombosis and myocardial infarction. And thank goodness, with the evolution of this technology, that fear has sort of fallen to the wayside. If you look then to finally, and this is supported again by the evidence of stent thrombosis at 5 years, that again the first generation drug eluting stents are leading the charge here. Which goes along with the previous slide. So at 5 years, patients who have had, even the newest stent technologies have not had a free ride. They've had additional events that we need to pay attention to. And here's multivariate predictors of who are the people that actually have these events. And you can see that continuing risk factors of diabetes, recent smoking, hypertension, and hyperlipidemia seem to contribute to continued problems with regards to stent treatment in these patients. Well, as you know, cardiovascular therapy always is evolving. We started out with, the kind of very direct and somewhat brutal approach of coronary artery bypass surgery, which is a remarkable technology, but nonetheless rather traumatic. And then these two characters, Grunsig and Hartzler, decided there was a less invasive way to treat this disease. And that initiated almost a 40-year odyssey of refining this technology to the point where you can see that on the bottom right-hand panel, that here's a chronic total occlusion being attacked from retrograde approach through, collateral channels with a surprising degree of success. This is a slide that's a combined analysis of the syntax and two other trials, and looking at the importance of complete revascularization, especially for the combined events of death, myocardial infarction, or stroke. And you can see that if you were randomized to a PCI strategy with multivessel disease and you had incomplete revascularization, that you had almost a 20% incidence at 5 years of death, myocardial infarction, or stroke. And that was considerably more than either CABG with incomplete revascularization or PCI with complete revascularization. And this looks at the same kind of analysis, combining it to patients with a very high syntax score, which is greater than 32 in this group. And you can see that, again, PCI with an incomplete revascularization has a much higher incidence of death, for example, in this particular study from any cause. So this raises the issue of, if we're going to go for a PCI strategy, that it may be rather important that we pay a special attention. And these are patients with stable angina to obtaining complete revascularization. So the big impairment to that, for the most part, has been the treatment of chronic total occlusions, and that most of the territories that are left unrevascularized in patients undergoing angioplasty have historically been territories that are supplied through a chronic total occlusion. And these are very frequent. You can see that the prevalence rate is somewhere between 29 and 33% found at routine catheterization, but the treatment of them is much less frequent, with only 6 to 9% being actually treated routinely, and there's wide variability between centers in that regard. And patients, however, with chronic total occlusions are different than those without chronic total occlusions. They're older, they have a higher burden of coronary artery disease, they have more diabetes, they have more peripheral arterial disease, they have more heart failure, and they have more chronic kidney disease. And these are very serious confounders that make observational trial results and comparisons between successful and unsuccessful CTO attempts very difficult to interpret. And randomized trials, which is the solution to that problem, have been difficult to enroll and complete. And there are only 2 trials, the Decision CTO and the Euro CTO, that have actually been completed thus far, and neither of them showed a survival benefit from intervention on CTOs. But that's not to say that it's a futile effort. Here's data from the Open CTO registry, which was published in 2017, and that's an American registry of 12 centers treating 1,000 consecutive patients with a coronary CTO. And these are all experienced operators. And you can see that by and large, the main reason to undertake this effort is for symptom relief in over 70% of patients. And most of the time, it's by appropriate use criteria considered appropriate or maybe appropriate about 80% of the time. And then they have this category called unmappable, which is actually very difficult to understand what they're actually talking about. But I think it has to do mostly with some patients are referred for CTOs and stage procedures in an effort to obtain complete revascularization. And they don't really fall into the standard AUC criteria. Well, what kind of procedures are these in this 1,000 patients? And I think what's quite remarkable in this slide is that the success rate was 86.2%, which is quite amazing for chronic total coronary artery occlusions. Historically, that's run around 50%, but with new techniques, wires, and different types of manipulations that are available, they've really improved this. But at a price of a longer procedural time, you can see it averages 2 hours here and goes up to 3 or 4 hours, not rarely. That also there's more radiation, averaging almost 2.5 grays and can go up above 5 grays, again, not rarely. And the contrast load is about twice that of a normal PCI. So you can see that these are more difficult procedures for patients to go through. Also, there are more complications than with standard PCIs. You can see that there's a 7% rate of overall MACE, which is higher than you would expect from routine PCI. And there's quite a higher incidence of clinical perforation of the coronary artery, being as high as 4.8%, which is extremely rare in routine PCI. And there is the other things are also more common, like access site hematoma, because the procedures are lengthy and the patients are on heparin, which is being repeatedly administered. But there is some benefit that takes place as a result of all this time and effort, and that is that the Seattle Angina questionnaire scores are better at 1 month than they were at baseline most of these patients, although they don't return to 100, which would be no angina. But you can see that the angina is quite minimalized in these patients. So what are the conclusions with regards to CTO intervention as a novel therapy for patients with chronic stable angina or chronic coronary syndrome? That it's a definite therapeutic advance for some patients, especially those that are symptomatic despite medical treatment and have well-defined ischemia on a stress test. Success rate with the new techniques and equipment have increased to 90% from about 50% 10 years ago, but there is a higher complication rate than non-CTO PCI. It should, however, in my opinion, be done in experienced centers by operators who do these cases frequently. The claims of improved survival should be viewed skeptically until results of well-run randomized trials are completed. So I think that when I refer my patients for this type of procedure, I want to know that they have angina that's going to be getting better, most likely, and that they have a significant amount of ischemia by some kind of non-invasive testing. Let's just talk about optimal medical therapy. And I think we all realize that the Achilles heel of optimal medical therapy is whether you're taking medical therapy. And this is an interesting article from the European Heart Journal from 2013, which looked at a number of studies, a meta-analysis, and it had a very large number of participants, as you can see, and adherence is not really great. The best is with aspirin, maybe, and that runs about 70%. But for statins, for example, 54%. For anti-diabetic regimen, about 69%, and antihypertensive, about 59%. So if you're not going to take your medications, optimal medical therapy is a problem. And this is why, as physicians, even in our patients that have gotten stents and revascularization, we have to be working with them on a continuing basis to be sure that we are keeping their risk factors under control. So here's an interesting drug that's come along that I think will have an impact on things, and that's a drug called inclisiran. And this has been developed by a small company outside of Boston. And then the medicines company decided to take it into sort of clinical trials, and then Novartis bought the medicines company. So this drug is under the purview of Novartis at the current time. And it's a small interfering RNA, and it targets PCSK9 synthesis. As you know, PCSK9 binds to the LDL receptor when it's incorporated into the hepatocyte and then directs it to be trashed rather than recycled back to the membrane to take out more cholesterol. So lower levels of PCSK9 confer protection from coronary disease. And this targets the production of PCSK9 rather than taking it out of the system once it's been produced, like the monoclonal antibodies do. Its great advantage is that it has infrequent dosing, and you can give an injection on a Q6 monthly basis with very good lipid control. And that potentially promotes appropriate MD follow-up. So you would theoretically go to your internist or your cardiologist every 6 months for your injection, which allows him to have, or her to have, very regular updates on your clinical condition. And the safety profile so far seems to be not significantly different from placebo. Well, how effective is it? This was a trial that, again, came out in April of this year at the New England Journal. April was a big month for new insights into the treatment of chronic stable angina. And what they showed was a rather remarkable reduction in cholesterol levels. So that you can see the LDL cholesterol levels declines about 40% on average from baseline. And with 2 yearly injections, it stays very stably depressed. And you can see that that's associated with a decline in the mean PCSK9 level as well, in the bottom right graph there. So I think this represents quite a major advance in terms of our ability to treat these kinds of patients. So in summary, I'd just like to sort of recap the things that we've been talking about. One is that chronic coronary syndrome is common and affects about 30 million Americans. And despite advances in medical and interventional therapy, death and MACE are at 5 years are not rare. Death being about 4 to 6%, and MACE being 12 to 16% in all those trials that I showed you roughly. Pitfalls in diagnosis still remain. There are confusing symptoms. There are false positive and false negative non-invasive testing. There's infrequent use of physiologic assessment before PCI. And all of these things make the diagnosis of chronic coronary syndrome difficult and require the attention and discipline of the treating physician. The ischemia trial again suggests that routine revascularization does not prevent death, but may decrease type 1 MI at a cost of periprocedural MI, but more long-term follow-up will be necessary to clarify that data. The ischemia trial clearly showed sustained improvement in angina compared to optimal medical therapy in patients with frequent symptoms. New interventional techniques allow angina secondary to CTOs, chronic total occlusions, to be more effectively treated, but these are riskier procedures and should be reserved for clearly perceived patient benefit. Aggressive, sustained medical treatment of known risk factors for coronary artery disease are more than ever a mainstay of management of patients with or without revascularization. Just because a patient had a stent placed or a bypass surgery doesn't mean you can leave these other treatments off the table. And newer lipid-lowering therapies promise, in my opinion, more effective control of hyperlipidemia in the not too distant future, which I think will have a major impact on the health and well-being of these patients. So in conclusion, I would just say to let common sense prevail. Be sure you are treating myocardial ischemia secondary to fixed atherosclerotic obstructions. Reserve revascularizations for those who will feel better, and don't worry so much about saving the patient's life. Worry instead about long-term risk factor control, emphasizing lifestyle modifications and adherence to appropriate long-term medical therapy. So that concludes my remarks about this particular topic, and I thank you for your attention.